So again, today we're going to talk about the respiratory system and some parts, some histology that you might not be learning so much in lecture, but who knows, you might be getting some of this in lecture as well. So respiratory is ventilation. I just want to put some terms down so you understand this. A lot of the students don't get this at first. First, you have pulmonary ventilation. Just to give you the terminology. So pulmonary ventilation technically is not exchanging any gases, and it's not. This is about air coming in from the atmosphere. You know, we're all at sea level here, and you have about, I would say, 756 millimeters of mercury pressure from the atmosphere. But the air has a lot of different things in it. It's got mostly nitrogen gas, mostly. And then, thank goodness, you got about 21% oxygen gas. And the rest is a little bit of CO2, thank God. And the rest, other than that, there's less than 1% water vapor, right? H2O vapor. So you're bringing all this in. Now, we can't do anything with nitrogen gas. It has no solubility into our blood. So we can ventilate it in no problem. It's part of the partial pressures that come in. Oxygen, we want a high partial pressure. And again, we're at sea level, so we get 21% oxygen in that atmospheric gas. And that's about 160 millimeters of mercury pressure coming into our lungs. That's really important. That's really good. So when you go up in elevation, right, if you go to Denver or anywhere that has elevation up to Whiteface Mountain, like Todd, where you're up about almost 5,000 feet above sea level, then the partial pressure of oxygen can go down a little bit. And that makes it harder to get oxygen into our blood. So pulmonary ventilation, which you're going to see in the virtual lab for the spirometry pulmonary function test, just tests how much air in a volume you can get into your lungs in one breath and then out of your lungs in the same breath. So one breath is breathing in and breathing out. So this pulmonary ventilation is about inhalation and exhalation. And the most important muscle for pulmonary ventilation, I think, is the diaphragm. You got to know about the diaphragm if you're going to study respiratory. Because you don't have to think about contracting your diaphragm, right? Just to take a quiet breath. You could use your diaphragm to take a deep breath in and your external intercostal muscles, and then you can use your internal intercostals to force an exhalation. But in a quiet breath, the diaphragm is innervated by the phrenic nerve, which is the cervical nerve on both sides, that innervates the diaphragm. So we have our respiratory centers in our medulla oblongata and pons, which you're learning in lecture, that can control that breathing in and out. You don't have to think about it. So that's number one, is pulmonary ventilation. This is about air. Then this one is really important when you're learning the respiratory system. This is called alveolar or external respiration. So now we're exchanging gases. Now we have O2 in, CO2 out, gas exchange. And this is between what? Between lungs and blood. So now you have your all those pulmonary vessels you learned about. Remember the pulmonary capillaries and the pulmonary veins, and pulmonary arteries? They're going to be, the pulmonary veins, of course, are going to be fully oxygenated, 100% hemoglobin saturation of oxygen. So this is important. Now we're into respiration, gas exchange. And then as the heart, remember the heart, that pumpy thing in the middle of your chest will pump blood into the distributing arteries and then into the arterioles and capillaries. Because next you're going to have tissue respiration. and that's internal. Respiration. Again, respiration. And that's oxygen, CO2 gas exchange. Those two gases now. You could probably guess between blood and cells, or blood and tissue. Remember, tissue is a group of cells functioning the same outcome. The last one, not last really, definitely not least, because this is what it's all about, right? The last one is cellular respiration. Remember this? I don't know if we did it. We don't talk about this. But this is what it's all about, really. Now we're using, remember, using glucose plus oxygen, and oxygen goes into the mitochondria. But the byproducts of glycolysis is glucose. So look at this. Oxygen goes into the mitochondria, and then you have the cycles, right? The Krebs cycle or tricarboxylic acid cycle, and the electron transport chain. And what happens? The oxygen in, and then the byproduct is a lot of ATP. I'll make this really big. ATP through aerobic respiration, plus what? What's the byproduct of cellular respiration? The waste product. Carbon dioxide, right? CO2. So that's cellular respiration. So first you have to have a good pulmonary ventilation. Make sure your lungs can take in a good volume of air and exhale it correctly. Then we have to perfuse that oxygen and carbon dioxide through external respiration. Of course, we're perfusing oxygen. That's really what we want in the vessels, pulmonary veins, of course. And then we have tissue respiration, which is delivering and perfusing the oxygen from the blood into the tissue so it could undergo cellular respiration. That's the whole gig, to make ATP. Because without ATP, how's that heart going to beat? It's not. How's your muscles going to contract? It won't. They won't. All of it, right? So you need glucose, of course, for anaerobic respiration, but we're talking about cellular aerobic respiration, which makes a boatload more of ATP than does anaerobic. Okay, so that's really important. So we're going to go down the path of respiration, which really starts in the nasal cavity. Although when you do pulmonary function testing, you're actually blowing, using your mouth to blow into a mouthpiece of a spirometer, or take a deep breath, draw a breath with the spirometer mouthpiece. But it really starts in the nasal cavity. So this is the histology of the upper respiratory system for the most part, especially the trachea. Oh, there's some cells that aren't here, not really telling you the whole story here. But this is a general layers of the upper respiratory. Like here's the lumen where the air is traveling, right? The oxygen, carbon dioxide, nitrogen. Remember, this is air. We're not exchanging gas in the trachea or the nasal cavity or the pharynx. There's no gas exchange there. In fact, there's no gas exchange in the trachea or the bronchi as well. There's no gas exchange in the bronchioles either. So this is all pulmonary ventilation spaces, conductive zones. So there's a lot of mucus and mucus producing cells. Remember the goblet cells? These are goblet cells. And this is the pseudo-stratified columnar ciliated epithelium that makes up most of the upper respiratory and part of the trachea, and the trachea as well. This could be the trachea too. Technically, the lower respiratory zone starts below the larynx, which we'll show you later. So again, you have a mucosa that has epithelium and mucus producing cells, and a lamina propria, which is loose connective tissue. The reticular or areolar. And then you have a submucosa, which is very vascular, blood vessels and glands that also are producing mucus, submucosal glands. So the cilia on the pseudostratified columnar epithelium is to move the mucus along the lumen or anything else that gets in the way. So cilia, which is these little hair-like structures, proteins, are for movement, not absorption. Like you learn in the digestive system that microvilli in the small intestine is more for absorption. So remember, cilia is for movement. Then we have this cartilage, supportive cartilage, because cartilage is strong. This is all collagen in here. And these are all chondrocytes in the lacunae. Hyaline cartilage, a lot of hyaline cartilage in the respiratory system, the larynx especially, and the tracheal rings, just like the costal cartilage. But this is around the conducting tubes. So most of the respiratory system has cartilage for support to keep the airways patent and open. Perichondrium, just the outer part of the cartilage. And then adventitia is connective tissue, like the outer part that's going to anchor these conducting tubes to other structures. So if this is the trachea, the esophagus is always posterior to the trachea. So there's a connection you'll see, and there's a muscle in the back of the trachea. But this could be most of the upper respiratory system, including the pharynx. So the pharynx is below the nasal cavity, which we'll see. So know these layers of histology. Okay, this is more of a close-up. You can see in the pharynx, really. And you see the epithelium, which is pseudostratified, ciliated columnar cells. And then, of course, every epithelium has a basement membrane. Remember, pseudostratified looks like it's stratified, but it's not. It's every cell is connected to the basement membrane. Then in the upper mucosa, you have a lot of vascularity, a lot of blood vessels. All right, again, we're not exchanging gas. This epithelium is not designed to exchange gas. This is to move mucus, produce mucus, and add some protection. That's all this is for. Not exchanging gas. And here's an olfactory gland. So now up in the pharynx, especially in the upper part of the nasal cavity, above the pharynx, you have olfactory glands, right? Or an olfactory bulbs and olfactory receptors for smell, because now we're up in the upper nasal cavity, upper respiratory. So these are always good. Before you go into a test, just take a look at these and see what the functions are. You know, basal cells, mostly for structure, and ciliated cells like the pseudostratified columnar. And goblet cells produce mucus. Lamina propria is more structure, connective tissue, right? Submucosa, and also the lamina propria could have part of the cartilage in there too as well, and the submucosa and submucous glands. So a lot of mucus, right? Mucin is the precursor to the mucus that's produced, and that's a protective mechanism, bringing mucus into the lumen of these areas. Talking about the trachea now. Trachea is pretty large, and I'll show you where it is. It's all respiratory, because now the esophagus will go posterior to the trachea, moving the food posteriorly, and you'll see that. So there's a lot of tracheal cartilage. There's rings of tracheal cartilage. Anterior. This is anterior in the front. And they're semicircular, C-shaped rings. So the C, the back, the open part of the C leaves space for the trachealis muscle, which is adjacent to the esophagus. Because when you eat in your burrito, you need a little room for that to be swallowed through deglutition and peristalsis. So the trachealis muscle is part of the trachea that kind of doesn't have cartilage, so that it leaves room for things moving down, bolus of food moving down the esophagus, which is posterior to the trachea. Always remember that. And adventitia, of course, connects it's connective tissue that helps anchor these respiratory tubes to other structures. So this is the trachea, and here's the lumen here. And this is anterior. And here's the esophagus, right? Posterior, which is very muscular, circular and longitudinal muscles that bring the food. So you can see clearly, you can see this is the cartilaginous rings. And I think there's about 12 to 18 cartilaginous rings that kind of come around the anterior, but not in the back. It's open because that's where the trachealis muscle is. See, it's right adjacent to the esophagus. So yeah, and it has its mucosa with epithelium and lamina propria. There is some muscle tissue in here as well. There is some light muscle tissue, but again, we're not constricting the trachea. That doesn't constrict, right? Like the bronchioles will. You'll see that later. Here's a little high magnification of the lumen, and you can see the mucin cells, goblet cells, and the pseudostratified columnar epithelium with the basement membrane. And then you see the lamina propria, which is connective tissue, just like collagen fibers. This is a little bit bigger. You can see the mucosa, the submucosa, and adventitia. And in the trachea, there's a good thick layer of hyaline cartilage, which is tracheal cartilage. So this is pretty much the way it goes. The lumen, the mucosa, which is your epithelium and some connective tissue, then outward submucosa and adventitia. If you remember blood vessels, you can remember the adventitia was always on the outside, like the tunica externa, but we're not using those terms now. Mucosa inner, submucosa in the middle, then adventitia on the external. Clear as a bell. So this is the histology of the trachea, which I really need you to know and take note of all those layers and structures, and note these semicircular cartilaginous rings, which is hyaline cartilage that is not complete, right? In the back, it's the trachealis muscle. Here's your point of view. Like Image Connect will show you a lot of this. So this is the larynx up here, and this is the trachea. And there's rings all the way down. I don't know how many. I think there's 12 at least. Okay, now the trachea. Again, here's the trachea. This is the hyoid bone up here. This is the larynx. We're going to do this anatomy again, so don't worry. This is the trachea. And now we're getting into structures called the bronchi. Bronchus is singular. So this is your left primary bronchus, and this is your right primary bronchus. It's the tube. Because the trachea is going to bifurcate. It's going to bifurcate there, right? So now we're introducing some smooth muscle into the picture. You see the lumen of the large bronchus, and the large bronchus could be primary, secondary, and tertiary bronchus or bronchi. Bronchi is plural, right? So the lumen is lined again with mucosal glands. It has a mucosa. There is more muscle now introduced into these areas. They still have cartilage, right? Here's your epithelium, and here's a large artery bringing blood into the lungs, right? And this is histology, so we're pretty deep here, right? We're pretty deep. We'll go through the larger structures later. So note the lumen, note the mucosa, including the epithelium, right? And know what a blood vessel is. Like, look at the smooth muscle in the wall of this blood vessel. That's a blood vessel. It's not an airway. So now we have to figure out where's the airway lumen and where's the lumen of the blood vessel. Crazy, all right? So now we're going out into tertiary bronchi, right? And we have more smooth muscle there too as well. All right, so now the trachea didn't have all this smooth muscle. Still have cartilage, and then there's a branch of the pulmonary artery, so we're bringing in less oxygenated blood from the right ventricle. Right. Now the epithelium changes. You see this now that we're in the tertiary, especially? The epithelium changes to not pseudostratified, ciliated, but now just simple columnar. Because we're getting closer to the area of magic gas exchange. We're still not exchanging gas. Anything you see here, we're not exchanging gas yet in these tubes. So now after the bronchi, you get into what's called a bronchiole. Bronchiole is a cute little bronchi. Now branching, and these are going to branch many times before they get to the area of gas exchange. All right, so these have a lot of smooth muscle. They lose the cartilage. Do you notice this? Now there's no cartilage. And you still have simple columnar epithelium. Right, again, that's for protection, keeping this area patent. Smooth muscle is very important in the bronchioles because now you're going to have control of the nervous system, the autonomic nervous system. So remember with the autonomic nervous system, when sympathetic stimulation was in play, it would vasoconstrict your blood vessels, right, to increase your blood pressure, to run away from that coyote here in Central Park when I'm having my burrito, right? But in the bronchioles, the sympathetic nervous system is going to cause bronchial dilation to increase the lumen of the airways, right? These are epinephrine receptors here. So this is really important. These are epinephrine receptors, adrenergic receptors. So the adrenergic receptors, the alpha adrenergic receptors on the smooth muscle in the airways, bronchioles, when stimulated with epinephrine, will cause bronchial dilation. So I could get more oxygen into my lungs so I can run away from the bear, of course. That's exactly, not the bear, the coyote. The bear was last time. So know this histology from the trachea or even the nasal cavity and the pharynx, right? Down to the trachea, into the bronchus, or bronchi, and then into the bronchioles. It changes, right? And this is great little table. Always helps you. This is with talking about the epithelium, the hyaline cartilage, right? Look at the bronchioles, none, right? None. So remember that. And this is where you're going to have that muscle constriction or dilation. Parasympathetic constriction, sympathetic dilation. Okay, so here we go. We're getting into it now. We're getting into it. So this is really where the magic happens. This is where the magic happens in the alveoli. Alveolus is singular. So divisions. So the respiratory bronchioles are still bronchioles. There's no gas exchange there. And look at this. Maybe you should learn this. Look at this. And this is why. Ciliated simple cuboidal, you're not exchanging gas in that epithelium. You don't exchange gas in pseudostratified columnar ciliated epithelium. You don't exchange gas in simple columnar epithelium. What epithelium do we use to exchange gases? That's right. It's simple squamous. This is designed a porous, simple squamous, one layer of squamous cells in a basement membrane, period. Just like the capillaries. This is for diffusion of gases. This is where the magic happens in the lungs. O2 and CO2. We're not putting nitrogen into our blood. Our cells would explode if we could put nitrogen. If you ever went deep sea diving, you know what I'm talking about. You run out of oxygen, you start using nitrogen, you're going to start bleeding from inside of your body. And have a terrible condition called the bends, because you need oxygen into your cells. Carbon dioxide is easy to get into the blood too, but we got to get carbon dioxide out. This is a waste product. Our respiratory system is run by levels of carbon dioxide. Our medulla oblongata is going to go crazy if you have too much carbon dioxide in your blood. And it happens. You're going to learn about emphysema, chronic obstructive pulmonary disease, asthma, chronic bronchitis, which could increase your levels of CO2 and cause an acidosis in your blood. So again, this is the area. the alveoli, right? So the ducts bring it into this bunch of grapes. And that's what it looks like, alveolar sacs. Like the alveolar ducts are kind of like stems bringing in air, really oxygen, hopefully, into the sacs are like bundles of grapes. And each alveoli or alveolus is like one grape. So you'll see the anatomy of that. So here it is. This is, and what's happening here? Is it pulmonary ventilation? Is it alveolar respiration external? Is it tissue respiration internal, or is it cellular respiration? Correct, it's alveolar respiration, which is external respiration, exchanging of gas. This is not pulmonary ventilation. All we did was bring air into the bronchiole. So the pulmonary ventilation ends here at the respiratory bronchioles. And they should be above. There's another one called terminal bronchiole right before that. It's not the same thing. So terminal bronchiole is kind of the end of the bronchiole branching. And then you have respiratory bronchioles technically going into the alveoli, but there's no gas exchange there. The gas exchange happens in the alveoli, the ducts, the sacs, and the alveolus themselves. I think I made myself clear. Okay, here's some of the cells in the alveoli, and this is good for lecture, and I will ask you as well. You have these macrophages in the alveolar sacs. I like to call these dust cells. And they're a second line of defense, right? So if you're stupid enough to smoke cigarettes or vape or something like that, or just, you know, or if you're just in the environment, right, where you're actually, you know, breathing in certain toxins or environmental things, smog and whatnot, we have these macrophages that will try to help phagocytize. These are immune cells, right? And blood cell that, as you learned at the beginning, macrophage is derived from the blood cell monocyte, right? So this is within the alveoli. Engulf phagocytosis, right? Microorganisms, hopefully, right? Your bacterias, your staph, your strep, your viruses, right? Influenza, COVID-19, if you ever heard of that. And then you have your type 1 cells. Type 1 cells are the true alveoli. This is where these are used for gas exchange. Type 1 alveolar cells. A lot of surface area, right? Tight junctions that keep the air within the air spaces of the alveolus and exchange it with the blood, right? You want good integrity of the alveolar walls, this simple squamous epithelium with the basement membrane, because they really have to function. And it's just air. Your lungs are extremely light because it's all air and the simple squamous cells. Then you have the type 2 alveolar cells, right? These are also have tight junctions. And again, these are more likely low columnar or cuboidal. It doesn't tell you that here, but they're not simple squamous because these guys, or girls, they're secreting surfactant. So surfactant, again, it tells you it's a glycosaminoglycan and protein phospholipid. But look what it says. Phospholipid, okay, phospho, that's polar, lipids non-polar. Glycosaminoglycans is polar proteins. So the surfactant reduces surface tension. That's its job. Surface tension. Because remember, these walls of these alveoli are, they're just light, simple squamous epithelium, and the lumens are filled with air. So, and they're operating under pressure, right? Because when you breathe in, it's okay. You increase the intrathoracic pressure, intrathoracic volume and decrease the pressure. But when you exhale, then you decrease the volume of your lungs and increase the pressure. So they're under a lot of pressure, these alveolar cells, and that creates a surface tension between the thoracic cavity and the lungs themselves. So that prevents, spell it right, collapse. And the word for collapse is atelectasis. That's collapse of a lung. So you need the surfactant, right? The surfactant, again, it's polar and nonpolar. Therefore, it's amphipathic. Amphipathic is like a detergent. You know what? My wife tells me there's like this machine in the basement that, like, when my clothes get dirty, they I don't know how it happens, but they go in there and they get clean. There's a dryer too. Well, there's a detergent she uses because I get a lot of stains on my clothes because I'm always eating stuff like a burrito with chicken and beans, and sometimes it's greasy. So you get a stain that's a lipid and a stain that's a protein, right? One's polar, protein, and one's non-polar, and that's the oil or the grease. So the surfactant is like a detergent where it makes the whole mess amphipathic, both polar and non-polar, so it could further be broken down and cleaned. So surfactant does that to the fluids within the lungs or around the lungs and alveoli. So it doesn't create high surface tension, keeps it mobile, keeps it being absorbed and reabsorbed and cleaned out. So sometimes like a baby's born, right? When little Todd was born, 12 pounds, 9 ounces, he came out and, his lungs haven't been working for 40 weeks. He's been relying on oxygenated blood from mom's placenta. So sometimes the surfactant, especially if he comes out early, surfactant's not being secreted yet from those cells down in the alveoli. So the doctor has to give you surfactant right away, so your lungs could expand and work against that surface tension from coming out into the new world. Right? So surfactant is type 2 alveolar cells. The gas exchange happens in the type 1 alveolar cells. So from now on, when we say alveolus or alveoli, we're talking about type 1 cells. And macrophages are macrophages, alveolar macrophages are dust cells. Get those right. So now you could see the tubes here. Get this straight. This is kind of confusing, but get this straight. You could see the tubes. And I'll go through the gross anatomy. Gross anatomy is what you could see with the naked eye. But these lungs are filled with millions of alveoli. You can't see that. It's just light tissue. It's parenchyma. Parenchyma is the functional cells of an organ, parenchyma. So the parenchyma of the lungs is truly the alveoli and the sacs. So this is histology of the alveolar sacs, basically. So you can see there's respiratory bronchiole, which is not gas exchange. It's like a vestibule between the terminal bronchiole and the alveolar sacs. So here's the ducts bringing in the oxygen, right, or the air, still air, until it's exchanged into the blood. And then all of these spaces, like this right here, is an alveolar sac. Each individual cell, like this one right here, is an alveolus. Alveolus is singular. Right? So this is part of an alveolus. This is a whole sac. This is a alveolus. This is a nice alveolar sac right here. This is an alveolar duct. So it's pretty good histology. You can probably see better. Check your textbook, see if you can see that better. This is an excellent high magnification of the alveolus. An alveoli, really. This is an alveoli right here. This is an alveoli. This technically is an alveolar sac because it's got like 3 of them. And you can see that dust cell. It looks nothing like a simple squamous cell here. And here's a type 2 cell. So generally, look at this picture and know that this is a close-up of the alveolus and alveolar sacs. And you can see all the types of cells here. All right, so see what MH Connect has to offer you with some pictures of this histology. See, do you have to do histology? Yeah. overview. So you have the microscopic anatomy, which you go through in the APR, right? APR. So hopefully you'll get that again. So here's the mid-sagittal, classic mid-sagittal. And you can see where the respiratory system basically starts in the nasal cavity, right? So these nostrils are nares, both sides. Then you have these membranes that line these structures called concha, superior, inferior, middle, and inferior nasal concha, right? So you have your respiratory epithelium is up in here, right? Here's the, remember the cribriform plate of ethmoid bone, right? Just above there. So that has the receptors for the chemicals of smell, right? So there's foramina in the cribriform plate. Then you have the posterior area. Well, here's what you need to know. The meatus is the space between the concha, lined with epithelium, very vascular. There's cilia, warms the air, and there's your first line of defense, which is the cilia in the nasal cavity, lining those meatuses. Good. So then you have the first structure below the nasal cavity is the nasopharynx, posterior to the nasal cavity. The nasopharynx right here. And basically that's all of this. Nasopharynx from here to there. So auditory tube is the eustachian tube that actually is a connection to the middle ear, to the pharynx. And that's made of elastic cartilage. Posterior soft palate with that uvula that hangs down. Not sure what that does, but has a gag reflex, nervous tissue. It probably was a vestigial epiglottis, which I'll tell you what that is in a minute. So I'm not sure exactly why we need that, but it's kind of cool. Like in cartoons, it looks like a punching bag, right? Now, the tonsils. In the nasopharynx, you have the pharyngeal tonsil, which is also known as the adenoids. You know, these are the ones that usually cause sleep apnea when they're inflamed. It's lymph tissue, immune cells, right? So these are the ones that are normally removed, you know, when you have chronic throat infections and things. Not sure if they still do that as often as they used to. So that's a tonsil. That's technically part of the respiratory system, but it really is immune cells. Here's the oral cavity. So, you know, kind of find out this big muscle thing is the tongue. Hard palate kind of separates the bony part that separates the oral cavity from the nasal cavity, and the posterior soft palate with the uvula hanging off. So the oropharynx basically starts below that uvula. And now we got a problem here because the food, right, the burrito's coming in the mouth, the air is coming in through the nose. So in the oropharynx and laryngopharynx, which is just inferior to the oropharynx, the food and air is mixing, right? So now we got to be careful. Remember, the esophagus is posterior to the trachea, right? So we have to divert the food to the esophagus, the burrito, right? So the epiglottis is what does that. That's elastic cartilage that's on top of the larynx, and it covers the glottis, which is the opening of the trachea. The vocal folds, the vocal cords, are just adjacent to the glottis. So the epiglottis will close that airway so the food can be diverted posterior into the esophagus. And the larynx, also known as like the voice box, right, has a lot of hyaline cartilage. Like the thyroid cartilage is anterior, mostly anterior. Cricoid cartilage is posterior and anterior. By the way, this is cricoid cartilage too in the back here. Okay, so this is the airway, the trachea with those cartilaginous rings. Like this is right here is tracheal cartilage now. So there's one row of cricoid cartilage, then it's tracheal rings of cartilage, which is called tracheal cartilage. So those are the general structures So the larynx, below the larynx, basically starts your lower respiratory tubes, conducting zone, or lower respiratory system, if you will, or zones. It's all conduction. There's no gas exchange. You didn't see any of that here. That happens all the way down in those microscopic alveoli. All right, so here's a little practice. They give you little, areas like the hard palate again, separates. I'm sorry, I forgot to mention the sinuses, right? Sinus, the frontal sinus here. And so go through these and see if you can figure out. Here's sphenoid sinus is here. Here's your uvula. This is your tongue, oral cavity. So you're looking at the pharynx, right? The nasopharynx and the oropharynx and the laryngopharynx. 6 is the epiglottis. 7 is most likely going to be the thyroid cartilage right here. And here's your glottis. Right? And this 8 would be your cricoid cartilage. 16 would be the trachea. So go through these, and again, you'll be doing your lab, doing the APR, and doing the atlas too. Atlas has a lot of models. You can really learn all those parts and fill these in, because again, that'll be on the test. So the larynx has a lot of cartilage. I installed the checklist in Blackboard. You can see the cartilage. You do have to know whether your arytenoid cartilage is. Right? Corniculate, it's on top of the arytenoid, but it's not in your list. Cricoid, you have to know, right, where that is. So hopefully we'll get a good look at that. You don't have to know cuneiform, epiglottis, of course, and the thyroid cartilage, not the thyroid gland, the thyroid cartilage. Thyroid gland, again, is slightly inferior to all this. Thyroid gland. The glottis is the opening, right? The opening of the trachea and the larynx. The remiglottis is the space between the vocal cords. You just have to say glottis, though. And then you have vestibular folds, which are called false vocal cords, right? False vocal cords, when the remiglottis is true. Just kind of semantics there. True. Vestibular is false. Remember, vestibular is false. Right? Vocal folds, the vocal ligament, and these aren't muscles, these are membranes, right? These epithelial tissue and connective tissue. So I would definitely know the true versus false vocal cords, what the glottis is, for sure. Here's the model, which you'll do in the atlas. Anterior view of the larynx. Remember, use this as a hyoid bone as a point of view, like a landmark. Then you could see like number 1 up there is going to be the epiglottis, which kind of sticks out. Like here's the epiglottis here from the posterior view. This is all thyroid cartilage right here. Here's your thyroid gland, which is a 2-lobe gland connected by what's called an isthmus in the middle. It's connected, so it's 2 lobes. Thyroid gland, which is endocrine, right? Endocrine. And then don't worry about the cricohyoid muscle, but these are all muscles we probably didn't even learn in AP1. There's so many of these muscles that aid in breathing and swallowing in this case. And then 5 would be your tracheal cartilage rings. So above, but actually here, like this ring, you gotta be careful, is usually the first, or the cricoid cartilage, like this is right here is posterior. You see the cricoid cartilage. You can see the thyroid gland just adjacent to the cricoid cartilage. And the thyroid gland has embedded glands called the parathyroid glands on both sides. There could be 2 on each side, completely separate endocrine tissue, right? Parathyroid hormone is released from the parathyroid gland. The thyroid releases thyroid hormone, T3, T4, and calcitonin from different cells. The follicular cells, remember, secrete the thyroid hormone, and the parafollicular cells secrete your calcitonin or thyrocalcitonin. So here's posterior, and you could see This is thyroid cartilage right here. Thyroid cartilage, right? And then right up in the middle, this is not a great picture of it. You can see the arytenoid cartilage. So when you're doing your lab, find out where arytenoid cartilage is. It's posterior only. It's like little, they look like those candies they give you at Halloween, the little triangles. And that's the arytenoid cartilage. Can't really see it so great here. The bottom is the mid-sagittal or lateral view. And again, you can see the epiglottis, the anterior thyroid cartilage here. And more posterior is the cricoid cartilage. There's your thyroid gland. And the true vocal cords would be 19, right? Your rim glottis. 18 would be your glottis. So again, this is not the best model, but look at the models, go through the atlas to see the difference in those structures, right? And this is the hyoid bone in the mid-sagittal view, just to give you some point of view when you're going through this lab. Again, this is, you might look familiar. Also, before, let me just see if the next picture will tell you, but the right side lungs, there's 3 lobes, and the left side is only 2 lobes. So again, this is the patient or the model owns the anatomy. So this is his left side, right? Left and right. And there's all your blood vessels. These are your pulmonary arteries here, and these are your pulmonary, the reds are your pulmonary veins going back to the left atrium. So same here. So these are pulmonary veins, and these are pulmonary arteries, and you have the airways in between. Like this is the left primary bronchi. This is the right primary bronchi. And always remember the diaphragm, right? That dome-like muscle that's going to descend on inhalation, contract and descend, and relax and ascend on exhalation. So the diaphragm contracts and lowers on inhalation and relaxes and ascends on exhalation. And we'll talk about that pulmonary function. Let's see if there's better pictures here for you. Oh, here you go. So this is the right lung, posterior and anterior over here. And you can see the 3 different lobes. And this is the horizontal fissure. 2 would be the horizontal fissure. 3 would be the oblique fissure. Where the left side only has that oblique fissure because it only has 2 lobes. Right? So you can't see the alveoli in here. They're just so microscopic. Right? And this is technically called the apex of the lung. This is the base. Again, this is the right lung. So the left lung has a cardiac notch, which you'll see, because the heart kind of digs into the left lung. It probably had 3 lobes at one time, but the heart took up most of the space in the left mediastinum. So it evolved into having 2 lobes. And lobes are usually divided further into lobules. A hilum is any area where all vessels come into an organ, like the kidney has a hilum. You'll see hilum, the blood vessels, your pulmonary veins are red and your pulmonary arteries are blue. Remember that? And here's your large bronchial airways, right? This big bronchial. So know the difference between airway and blood vessel and fissures. So your lower lobe, your upper lobe, or superior lobe, inferior lobe, and middle lobe. Or the right lung. Left lung only has 2 lobes. Here we go. Here's the 2 lobes. And it just has an oblique fissure, which you could see that. So the bronchial tree starts with the trachea, of course, and then branches into the bronchi. So right here, you could see, again, this is the larynx. Now we're going to the lower respiratory below that. Here's the hyoid bone up here, hyoid bone. This is cricoid cartilage. This is tracheal cartilage. So the cartilage goes, this is the epiglottis, which is elastic cartilage. This is thyroid cartilage, which is hyaline cartilage. This is cricoid cartilage. And now you get into tracheal cartilage rings. And it wasn't mentioned before, but this bifurcation spot right here, where there's a fork in the road, is called the area of carina, or carina, whatever you want to say. And that's an area of a cough reflex. So there's nerve tissue. So that's another second line of defense right there, too, in case any foreign particles get into that area, especially that area of bifurcation. And number 5 would be your primary bronchus, left primary bronchus. And it's bronchi is plural. Then it'll branch further into the secondary bronchus. So usually the bronchus will divide into lobes. So the left lung will have 2 main primary bronchi. Two main secondary bronchi, because there's 2 lobes on the left. All right, so the other side would be your left. So this, again, you have to say left. You have to say left. Because over here, it's the right secondary bronchus, and so forth, so on. Here's the right primary bronchus. Simple things that you don't want to get wrong, right? So 2 would be your tertiary bronchus, where it branches even more. And remember, this is the right side, and this would be your left tertiary bronchus. Bronchus is singular, bronchi is plural, and this would be your trachea. Again, none of this is exchanging gas. You saw the histology from pharynx, larynx, trachea to bronchus. Right? And then the tertiary bronchus will now branch into bronchioles. Right? So that's really important. So we'll do the respiratory respiratory function. We'll just take a second to ask some questions. So here is the capacities. So I like to start here with your tidal volume. And then showing you in milliliters. Of course, this is, for a demographic, right? So this is the lowest amount of air. It's a quiet breath. It's just without thinking about it. And this involves inhalation and exhalation. One breath. So it's 500 milliliters. Now, this whole thing about normal values, you have to know your predicted values for you being, or me, I'm a 25-year-old female from Singapore. So you have to take all that into account, all those demographics, and your height and weight and date of birth, right? Where you're from, all important. Gender is important. You have to take the predicted values to find out if they are normal. So these could be all over the place. And here's the rule of the Thoracic Medicine Society, that in order to have a normal volume, it has to be 80% of your predicted value for who you are in demographics, right? So tidal volume is just breathing normal. And you can measure that over one breath, or you can measure it over a minute. Now, this doesn't mean that all that tidal volume over that minute is going to be used for gas exchange, because it's not. You're going to learn about anatomical or physiological dead space. So the actual amount of air being used for gas exchange is a little bit less than the average of your tidal volume over a minute. But technically, tidal volume is only one breath. Now, if I ask you to take a deep breath above the tidal volume, that's your inspiratory reserve volume. So that adds another 3,100 milliliters. Well, actually, I'm the female, right? So that's 1,900 milliliters. It's significantly less, but again, it should be 80% of your predicted value for who you are. Then I tell you to blow out all that air that you just breathed in. Remember the diaphragm, when I told you before about the diaphragm lowering on inhalation. Using other muscles like external intercostals are important for inspiratory. Internal intercostals are for expiratory. So if you take the tidal volume, you add the inspiratory volume and the expiratory reserve volume, you're going to get what's called the vital capacity. And I think this is the most important of all capacities, because it's one breath, right? But it involves, and why is it so important? Because it takes in 3 things into account. The way you breathe normally, which even in sick people doesn't change very much. You could have a normal TB and have emphysema. But these two, this is inhalation and exhalation. So vital capacity is a very important value. Then you have this residual volume. So this also prevents atelectasis because this is air. Remember, this is air, not just oxygen. This is air. So the residual volume is air left in your lungs, even after an expiratory reserve, like breathing all the air out of your lungs using your rectus abdominis and internal intercostals and obliques. So it's not like this air stays in there the whole life. Like when Todd's born, that air doesn't stay in there from the time the doctor smacked him on the ass. But this is air that's going to be used ultimately for gas exchange, and it's rotated out. It doesn't just stay there; it's rotated out with your ventilation. And remember, we're talking about ventilation here, pulmonary ventilation, not respiration. Inhalation and exhalation, but we're not exchanging gases here. We're just getting the air to the alveolus. So if you add all these three together, if you take this into account, your residual volume, that's your TLC, your total lung capacity. So the vital capacity is just the TV plus IRV plus ERV, where TLC, you add in the residual volume. Cool, cool. So this is important too, because, there's a condition you're going to learn, and it's part of chronic obstructive pulmonary diseases called emphysema. Emphysema is a condition where your alveolar walls are destroyed, mostly from smoking, but you could have really bad luck. It could happen genetically too. So your air cannot be exhaled out of your alveolus or alveoli or alveolar sacs. It stays in there. It's kind of like blocking exhalation of carbon dioxide. So in a case like emphysema, this is really important. I hope you get this. In a case like emphysema, your residual volume is going to go up. So this number can go double. And now sometimes predicted values, right? I said 80%. If it goes above 120%, that's very high. And you're going to have excess carbon dioxide in something like this. Somebody has a question. Hold on. Question? I can't see the chat. I'll go back to it. All right. So the RV is important as well, not only to prevent, help the surfactant to prevent atelectasis, which is collapse of the lung, but also it has to be homeostatic. It has to be within 80 to 100% of predicted values for whoever you are. Then you have these functional residual capacities. It's just simply adding the exhalation or expiratory reserve volume plus the residual volume, and that has a normal value as well. And inspiratory capacity is just the TV plus IRV. So that's everything that you're getting from this, right? So again, this is your TLC again for this guy, and this is TLC for this gal. And here's your vital capacity, because the vital capacity doesn't involve the RV, the residual volume. So remember, vital capacity, and all this is one breath. None of this is over a minute. That's really important. So in lecture, you might learn what's called minute volume, which is basically your tidal volume over a minute times your respiratory rate. Respiratory rate is how many breaths per minute you take, which I believe should be between 16 and 22 or something like that. But I'm not interested in that right now. But you may learn that in the lab. What your book says is normal respiratory rate. So that's minute volume, but technically tidal volume is only one breath. Vital capacity is only one breath. Total lung capacity is only one breath. And you told me before, in units, milliliters in this case, but it can be converted to liters. Same thing. It's all volume of air, not just one gas. Whew. So here we go. I guess we could read this left to right, but it doesn't really show you the vital capacity. Let me see. Yeah, it doesn't really show you the whole the whole picture in one breath. So if you look left to right, here's your tidal volumes, right? Your tidal volumes. And like, I guess this is doing a male, would be about 500 milliliters, right? And then if you have to do an IRV, remember, if you do IRV, right, you have to take into account the tidal volume plus the inspiratory reserve. You have to add those two. You can't leave this out. It's two values. And then you're taking a couple of tidal volumes, normal breaths, and then you're asked to breathe out. That's forced exhalation. And that's below the tidal volume. So for ERV, expiratory reserve volume, you have to add the tidal volume plus the expiratory reserve. Right? Now the residual volume is just that air left in. It looks like about 1,100 milliliters or so in this particular picture. So this is really important, your vital capacity. So your vital capacity equals, remember you have to add all of these, tidal volume plus your IRV plus your ERV. Your total lung capacity equals your VC, which is vital capacity, plus your residual volume. And it's all in liters or milliliters, and it's all one breath. This is one breath. This is one breath. And it just kind of doesn't really show you that because it's making you kind of do it through, a bunch of breaths. So basically know what the functional residual capacity is. You can see that's the ERV plus RV, and your inspiratory capacity is your TV plus your IRV. And here's your TLC, all of the volumes. So you should be able to plot those out. I probably won't ask you to do that, but just know what they are and know what the units are. And it's pretty easy if I did ask you, how to, get the 6,000 total lung capacity, or get the total lung capacity, and you have to divide that by the predicted value to get at least 80% for it to be normal. Predicted value for you, your demographics. So this is kind of describing Boyle's law in a way. I'm not going to put you through this little experiment here because you're going to do that in your virtual labs. So this is a very rudimentary looking pulmonary function test. Now, I have a couple of problems here. Again, he has a mouthpiece, right? And of course that's disposable. We couldn't do this in lab even if we were in lab because of COVID. But this nose should be pinched. You got to pinch that nose. You can't let any other air besides what you're dealing with here. Okay, so he has to breathe either. It depends on what test you're doing, right? If you're just doing a spirometry for those volumes, you could basically take an inhalation. It could be your first breath into the mouthpiece, and then you start recording at the same time as a tech. A respiratory tech has to press that button at the same time. So again, this could be testing the volumes, right? The indicators are rudimentary, right? Against some pressure, and the water tank provides some pressure. So you kind of pump against it, and you could record those volumes in milliliters. And once you record those volumes, you can get your tidal volume, your expiratory reserve volume based on the readouts. Inspiratory reserve volume, tidal volume, plus your expiratory reserve volume, then you could do your capacity, vital capacity. And it's pretty good. You do it, 5 times. It's only 5 breaths. So a vital capacity, which is the most important, is you take tidal volume, then ask the student to take a deep breath in as much as they can. Don't hold it. Just take as much air as you can get in and blow every bit of that air out into the spirometer. And your mouth is on the spirometer the whole time, starting at the tidal volume. And then you get an average. And then you you divide that by the predicted value for who you are demographically. And it should be 80%. So vital capacity is important, again, because it takes into account inhalation and exhalation. Because most obstructive conditions like asthma, emphysema, chronic bronchitis, cystic fibrosis are obstructive conditions. And those obstructive conditions, the problem is mostly with exhalation. So it's going to affect your ERV more than your IRV. But either way, it's affecting your vital capacity and lowering it below predicted value 80%. So that's why the tidal volume is so important. And then you can calculate your functional residual capacity and then your inspiratory capacity. And of course, you have to get your residual volume to calculate your TLC, because TLC is what? Equals your vital capacity plus your residual volume. IC equals your tidal volume plus your inspiratory reserve volume. Functional residual capacity is your expiratory reserve volume plus your residual volume. Okay. So those are the calculations you'll get, and you'll have to do that. I mean, again, it's very straightforward. Once you learn those capacities, you're good. This looks like they're calibrating their machine. Usually they use like an artificial lung. That's usually about 3 milliliters, or 3 liters, sorry, liters. And they'll make sure that the machine is calibrated to get the right look, right? And this is what you might see in your virtual labs. So again, dry spirometry. And here you go. You measure it, you calculate it, look for the normals. And they give you a range, that's a lot easier. But the machine's going to tell you this on those spirometers. They're going to tell you. So again, this is all about pulmonary ventilation function. A ventilation, there's no gas exchange here. No gas exchange. And you can plot it out. Now, of course, this is a whole different story here. Now we got to take into account the partial pressure of oxygen. This is kind of important. Now, this is based on where you live, again, with ventilation. So the partial pressure of oxygen at sea level is like 160 millimeters of mercury. So this is not liters anymore. This is millimeters of mercury. There was another dead guy. His name is Dalton. He says that in the atmosphere, each gas that's in the atmosphere, like nitrogen, oxygen, carbon dioxide, exert a pressure on your lungs as if they were acting individually. So, of course, we're interested in the partial pressure of oxygen, which is measured in millimeters of mercury. So at sea level, that's about 160 millimeters of mercury, which is excellent. But as you go to higher elevations, that could be significantly lower, like 113 millimeters of mercury. It's really hard to go through your respirations, like alveolar respiration and tissue respiration, if the partial pressure of oxygen is low. So you're going to be in respiratory distress when you go to higher altitudes. So that's really important. And of course, if there's something else going on, like I mentioned the obstructive conditions, which are more about exhalation, but restrictive conditions like pneumonia, tuberculosis, of course, and other respiratory problems of the parenchyma of your lungs can cause restrictive conditions, which make it hard to take breaths in, inhalation. Doesn't matter what the partial pressure of oxygen is in that case. So then we have to worry about how much of oxygen is getting into the blood, because ultimately it's about what? It's about perfusing oxygen in the blood to your tissues so you can make ATP. That's perfusion is in the blood. Ventilation is about the airways. Perfusion is blood. Ventilation is airways. So again, looking at different pHs, really important. So this is where we want the pH of blood. This is where we want the partial pressure of oxygen in the atmosphere. Now in the lungs, the PO2 in millimeters of mercury now is around 100. And you're going to learn about hemoglobin saturation of oxygen. Should be between 95 and 100%, especially at a partial pressure in the blood of 100 millimeters of mercury. Again, for lab, you don't have to worry about that so much because you're doing your pulmonary function tests, right? Just ventilation. So you'll see that in the lab exercise. You'll see and different situations like post-exercise, right, which is important. So you go through that and you'll do a little exercise. Hopefully that'll be pretty comprehensive. I liked it. I did it over the summer. I thought it was pretty great. That particular one. For McGraw-Hill, we used to use Pearson, but this is really easy to use. And again, you have 3 attempts. So I don't see why you don't get 100 on all of those. And everybody's been getting 100 on